All right. Hello, everyone. Thank you so much for joining tonight. If you are here for the GeneSight Engage webinar, you are in the right spot. So thank you for coming. We will let people filter in. We make sure. Yep. Okay. The numbers are climbing, so I'm just going to give it 1 minute and then we will go ahead and get started. And a thumbs up if you can still see my screen okay. Awesome. Okay. All right. As people start to funnel in, we will start and do some introductions and start with an overwhelming gratitude for thanking you for taking the time to be here on a work week, a work day, at night. We really appreciate your presence. You are here for another GeneSight Engage webinar. So these webinars are designed to promote appropriate utilization of the GeneSight Psychotropic Report. And my name is Dr. Rachel Earls. I will be your moderator this evening. So if you have any questions, please direct your questions into the Q&A feature of the Zoom meeting, and we will answer what we can as best as we can during this webinar. And we will follow up with a recording. We're hoping to have the recording posted by the 12th, but we will get it uploaded to our YouTube channel as quickly as possible. If you have any questions after this webinar, please feel free to reach out to our team at GeneSightEngage@genesight.com. Again, that's GeneSightEngage@genesight.com. In our previous webinars, we discussed different sections of the GeneSight report, including the interpretive portion of the report, where medications are binned into one of three color-coded categories. We've done another webinar on genotypes and phenotypes results, what that means. We also looked at how to interpret the gene-drug interaction chart. And more recently, we reviewed how to appropriately interpret the clinical considerations of this report. And then we learned how and when clinicians are actually using this type of testing in real-world settings. In this session, we're going to dive into a new topic. We're going to explore how currently available pharmacogenomic tests on the market may differ from one another, and how these differences may have a significant impact on report results and clinical outcomes. So we're going to dive into the standards that GeneSight uses for GeneSight selection, review the approach used by the GeneSight test to predict medication outcomes, and lastly, we're going to talk about the totality of evidence for psychiatric pharmacogenomics. And most importantly, we're going to hear from our panel of clinicians regarding how these differences may have led to their consistent use of GeneSight in their clinical practice, and learn any other notable differences that have made an impact for them in, made an impact for them in their clinical practice and patients. So without further ado, here tonight we have three speakers from Myriad Genetics. First, we have Dr. Crystal Nelson. Dr. Nelson is the owner and CEO of Blueprint Psychiatry in Noonan, Georgia. She's a graduate of Spelman College in Atlanta, and she earned her doctorate of medicine degree from Morehouse School of Medicine, completed her psychiatry residency at Virginia Commonwealth. Dr. Nelson also has additional training in geriatric psychiatry from Emory University, as well as training and certification in transcranial magnetic stimulation for treatment-resistant depression. Her medical philosophy is to honor the uniqueness of each individual client with a customized treatment plan. Hi, Dr. Nelson. Thank you for being here today.
Hi, Rachel. Thank you so much for having me.
Next up, we have Dr. Justin Wyrick. Dr. Wyrick is a primary care physician who earned his Doctor of Osteopathic Medicine degree at West Virginia Medical School and completed residency in Fort Wayne, Indiana. As an osteopathic physician, he focuses on treating the whole patient using mind, body, and spirit as important pillars of health. This is where his growing passion for pharmacogenomics fits in, allowing him to treat each patient on a more personalized level, which he truly believes is the future of medicine. Thank you for being here tonight, Dr. Wyrick.
Thank you for having me.
And last but certainly not least, we have Anna Marie Pietro, who is a board-certified family psychiatric mental health nurse practitioner. She received her training in mental health psychiatry and advanced practice nursing from the University of Pennsylvania School of Nursing. She specializes in the field of adult and pediatric psychiatry with the focus of ADHD, eating disorders, mood disorders, anxiety, autism spectrum disorders, intellectual disability, substance abuse, personality disorders, among others. We're so grateful to have you here. Thank you, Anna Marie.
Thanks so much.
All right, let's begin. It's enough introductions. So I would like to start our conversation opening the floor to each of our panelists by asking when and why you started using pharmacogenomic testing in your practice. Anna Marie, would you like to begin?
Sure. Well, we were just joking before the presentation started that Rachel was in undergrad when I started using GeneSight. So that was a long time ago. Um, I did a switch because as I was saying earlier, I used to use the saliva collection tubes. That was the only way that I knew you could do pharmacogenomics. So when GeneSight came knocking my door down as this new company with a swab, I was like, sign me up. I don't care about anything else. Luckily, I learned a lot after that, and I've never looked back. So since I switched to GeneSight, which I think that was probably 2012, 2013, I've exclusively used GeneSight since.
And what piqued your interest to want to start using pharmacogenomic testing?
So this is actually a funny story. So I had a lot of students that would work with me doing their nurse practitioner clinical, and I was working on a particularly tough case with one of my students. We were sitting in my office and I was talking through ideas with her, and she was like, "Well, have you ever considered like maybe this kid is a poor 2D6 metabolizer?" And I was like, what? What does that mean?" Um, and she was a Penn student, the program that I went to as well. So I'm thinking to myself, like, how does my student know something that I don't know? So immediately I went and like researched everything on the possible face of the earth about pharmacogenomics. And I was like, well, clearly if my students know, I must know too. And since that day she said that, I've just been interested in reading more and gotten into it and done the testing ever since.
Awesome, thank you. What about you, Dr. Wyrick?
My story started with a patient walking in, classic patient who'd been through the ringer, a lot of different medicines tried and failed, and they actually specifically requested a GeneSight report that I order for them. And so, without having an established portal or any access to GeneSight, I reached out and got a sales rep in to kind of talk me through a little bit about it. My understanding of genetics at that point was pretty slim, and I had seen some reports, none of which were GeneSight, and didn't really feel like I knew much of what to do with them. But for this in particular gal, we went ahead and got a GeneSight. She came back, we went through the report, and it was a huge success story right out of the gate. And that kind of spoke for itself. And so I kind of dabbled a little bit more with other patients, and it's just been, yeah, no look back since then. So it fits really well into my practice, and it is really a key piece to how I ultimately look at mental health and how we individualize things.
Thank you. And what about you, Dr. Nelson?
Well, I'm right there around the same time, I think, as Anna Marie. I want to say maybe 2012, 13, 14, around that time. It gets blurry because I had kids. So it gets real blurry around that time, but it's been a while. I was interested because I can really remember in residency and in med school, we would talk about the promise of doing precision medicine, that one day we would treat patients by using their DNA. So when pharmacogenomic testing kind of hit the psychiatric scene, I was ready. I was like, okay, great, here we go, precision medicine. And I tried several other companies prior to GeneSight. But since using GeneSight, it's changed outcomes. So I was primed and ready for it when it showed up.
That's wonderful. Thank you for sharing that. So as the panelists have alluded to, there are numerous pharmacogenomic test reports available on the market. So I want to take a few minutes to discuss what truly makes GeneSight different. And here on this slide, you can see that there are three main differentiators between pharmacogenomic products on the market that we will discuss tonight. The first differentiator we're going to talk about includes criteria for inclusions of genes on the GeneSight report. So on this slide here, you can see the list of genes that are included on the report. You're going to see 9 pharmacokinetic genes or drug metabolism genes here on the left, and 5 pharmacodynamic genes here on the right, which can tell us information about potential changes in efficacy or side effects for particular psychotropic medications. And so when you think about it, the human genome contains, approximately 20 to 25,000, depending on where you look, different genes. So why were these genes included? Why were these genes selected? And the GeneSight psychotropic report only includes genes that have variants present with significant impact on medication outcomes. Or put more simply, will variation in this gene actually have an effect on outcomes for patients? And that may seem kind of intuitive. You may think, well, shouldn't they all? But that's not necessarily the case. Secondly, this phenomenon has to be demonstrated in multiple well-designed studies in numerous independent patient populations. GeneSight will not include genes on the panel that have not been demonstrated in multiple patient populations because we want to show that this is replicatable amongst numerous people, independent people. And lastly, these variants have to appear at a high enough frequency to be meaningful clinically. So there are definitely rare variants out there that are seen, a dime a dozen, but if they don't actually affect a significant portion of the population, they won't be able to provide information to most of your patients. So I'd like to ask the panelists, have you ever utilized or seen any other pharmacogenomic tests that maybe include different genes, more genes, same genes? What has been your experience? And anyone feel free to start on this one.
Well, I'll start. I definitely had used other companies, and I always share when I'm talking to nurses and doctors about GeneSight. Funny story, my husband worked for another company and he used another test, and I was ordering quite a few pharmacogenomic tests, and he would say, "Man, why aren't you using my test?" And we were dating at the time, and I didn't know whether or not to be honest and tell him that his test was crap. I mean, it was a lot of genes. That company's gone out of business, by the way, but it was a lot of genes, and it really was not changing the outcomes that I would get. So I wasn't really getting anything actionable, and it was very difficult to decipher, even though if you set them side by side to GeneSight, there was a longer list. But just because there were more genes didn't mean it was really giving me more valuable information. So, yeah.
Yeah, I'd say the same thing. I came across plenty of other multi-gene tests out there. I've never seen a single gene test, but I've seen lots of multi-gene, but those aren't the weighted ones. And it just seems like data overload. And so when I talk to my fellow colleagues about it, I oftentimes, give them an analogy about, do you want a electronic health system or health record that has tons of bells and whistles and lots of data, but you are not efficient using it? It makes you slow down and do tons of clicks, and it makes your day boggier. Or would you rather have an EHR that is, really simple, helps you be very efficient and actually get through patients quicker and, yeah, again, more efficiently? And that's really how I look and compare GeneSight to some of the other products that I've been exposed to. Just too much data, and it leaves the provider to have their own knowledge base to know, well, is this gene really that impactful for this medication or not? And so most providers are scared away just because they see one gene, one drug. Well, I don't know what to do with it, so I'll avoid that. Whereas GeneSight would give you that insight. Hey, you do not need to adjust here. Just feel comfortable using it.
Thank you.
As I mentioned, I was using pharmacogenomic testing prior to GeneSight coming out. So I did actually do single gene studies because that was all that was available then. And that was extremely challenging. I had probably 4 or 5 students at the time. And so when we would get these single gene reports back, I would then say, like, okay, we're considering sertraline. So go research the percentage of sertraline that's metabolized by 2B6 versus 2D6 versus 2C19. And let's try to investigate and figure out what we should do as a result of these results. It didn't give any meaningful information. And it definitely didn't give any information that I could use on the go. Just like both of my other panelists just mentioned. It's that we're about to walk into a patient's room, and especially in primary care, I say this to my primary care providers all the time that I speak to. Sometimes you have 30 seconds before you walk into the room with a patient to be like, okay, I have these results. What am I going to do? Is this going to be actionable? And with GeneSight, you can look at that report. You can, once you've utilized the report a little bit, you can page to the ones that are going to change your mind about what you might prescribe or not prescribe, or what dose or whatever. And within that 30 seconds, you can look at a report and know, should I change my mind about something I was going to do, or where should this conversation with this patient go? Because if you have a 20-page report sitting in your chart and you're 2 patients behind, you're not going to sit down at your desk and be like, let me see what genes in this report are going to be helpful for the conversation I'm about to have. You're going to table that for another day, and then you may never get back to it. But with GeneSight, you can go into that room, even if you haven't even looked at the report. You have a conversation with the patient, an idea pops into your head about a medication, you look down at your report, you see where it is on the report, and then look at the clinical considerations. And in all the reports I've used, the single gene ones, and each time that I've tried other reports over the years, none of them give me that same like quick and easy look and go. The rest are, I'm trying to figure out, like, why is this gene telling me that I might have schizophrenia? Like, those are things that are really not helpful in a report for a provider or for a patient to see. So the information might be there. There might be enough research to potentially support it, but the clinical utility is questionable, I think.
That makes a lot of sense. So the big takeaways I'm hearing is efficiency, usability, interpretability. Those things really matter in real clinical settings. And so maybe having hundreds of genes tends to be more overwhelming than useful. So that's incredibly helpful. Thank you for providing your insight there. One thing that I would like to point out is that at the top right of every GeneSight report, there's a phone number and email address that sometimes doesn't get enough attention. And this will connect clinicians and patients to our on-call medical affairs team. So these are MDs, PharmDs, and PhDs to answer any questions you may have about genes on or off the report. So if you have a question about a gene, you're like, I wonder why that's on there, I just want to understand or learn more, this is the team to call. We can help you understand why it's not there, what data we're able to see to come to those conclusions. And I also mentioned that there is a phone line, the same one here, for patients as well. If patients have questions, they can be connected to genetic counselors who can help them with them as well. So this is on the top right of every page of the report. And this team's entire job is to provide clinical support, not only on report interpretation, but general pharmacogenomic knowledge as well, which would include why certain genes are or are not on the panel as well. So the second differentiator we are going to talk about between GeneSight and competitors is how we measure the impact of multiple genes on medication metabolism or efficacy in a unique weighted approach. And this is called the weighted multi-gene approach. So I'm going to take some time to explain this. And it's really important to note, if you take one thing away, is that not all tests utilize the same methods when they analyze the impact of genetic variation on medication metabolism or efficacy. There are multiple types of pharmacogenomic tests on the market, and it's important to understand why they differ and how they differ, and how this may affect your decision-making clinically. So the first and most common type of pharmacogenomic test, which you've heard our panelists speak to a little bit already, is called a single gene pharmacogenomic test. This test looks at one gene that's highly influential in the metabolism or mechanism of action of the drug and gives you a genetic result based on that one gene. So illustrated here, you see the example of drug X or drug Y being associated with CYP2C19, so CYP2C19. They would give you information based on the genetic results of that one gene. Another type of testing is called multi-gene testing. Like single gene testing, except with multiple genes are tested to associate genetic results with medication metabolism or mechanism of action. So a multi-gene pharmacogenomic test does not account for some genes having a larger or smaller impact on medication outcomes than others. And it can result in different treatment recommendations for a single medication. So if we look at the example for drug Y here, you can see that this mock multi-gene PGX test looks at CYP2C19 and CYP2D6. It will provide separate results for each of these two genes here, and it will treat each of these genes as if it contributed equally to this drug's metabolism, even if that's not necessarily the case. So it will provide separate outputs for each gene driven pair. The last type of pharmacogenomic testing, which is utilized by the GeneSight test, is called a weighted multi-gene approach. This approach looks at the effects of multiple genes associated with medication metabolism or mechanism of action and assigns each of these genes weight. So this weight is illustrated by the different size circles here. So for drug X, we would think that CYP2C19 plays the largest role, and CYP2D6 and 3A4 play smaller roles. These weights indicate how much of a role these genes play on this medication. And the GeneSight algorithm integrates all of this information into a singular output, which is shown by our binnings, so our green, yellow, red bins, and clinical considerations. So the real question, why does this matter? Why should you care about this as a clinician? Do these methods really have any differences in outcomes for patients? And we have 3 studies here that indicating when a weighted multi-gene approach is actually used, it is a better predictor of medication blood levels of certain psychotropic medications compared to if you just look at a single gene alone. And one of these studies showed that the weighted multi-gene approach was actually a better predictor of clinical outcomes as well compared to single gene testing. And importantly, if you focus your attention to this graph here on the left, what this shows you is that when you use this approach, so looking at multiple genes and their relative contribution, you can actually identify 5 times more patients with genetic results that indicate a significant gene-drug interaction rather than just looking at single genes alone. So looking at the impact of multiple metabolic pathways for each medication has been shown to have better predictability of blood levels of drugs and clinical outcomes. So when you ask, why should I care? This is kind of the reason saying why this is important, because these methods can lead to different clinical outcomes. And so we're going to have one of our panelists, Anna Marie, actually review a patient case study to illustrate the differences and potential clinical actionability and recommendations when utilizing these different methods. So Anna Marie, I'm going to turn it over to you, and you just tell me when you're ready for me to change to the next slide.
Okay, great. So this is a 29-year-old female. She has a diagnosis of major depressive disorder, but also struggles with generalized anxiety as well as borderline personality disorder. She was having symptoms that included depression, fatigue, low libido, anhedonia, irritability, poor sleep, hopelessness. She had tried a lot of different medications in the past. Those are listed in front of you. Some of them, sertraline, venlafaxine, duloxetine. At the time of the testing, she was on escitalopram and propranolol, and the drug that was being considered prior to receiving the GeneSight testing was citalopram. So with doing the GeneSight testing, the goal was to look at, one, is citalopram a good choice by nature of the type of medication it is and its mechanism of action, and also how should we dose the citalopram. You can go to the next slide. So I mentioned I've done all 3 of these types of testing before. So if I was just looking at single gene testing and I looked at CYP2C19, this person came back as an intermediate metabolizer phenotype. So if we're looking at that alone, you would initiate the citalopram at the recommended starting dose. You wouldn't think to adjust it at all. It wouldn't make that clinically significant of a difference. So we would just move forward, initiate it the same as I would have without the testing. Now, even if I did multi-gene testing and I got a report back, which the previous reports before I switched to GeneSight did have multiple genes, but they didn't synthesize information. So this is when I mentioned when I'd have my students trying to investigate how do we piece these together and what percentage quantity are they significant, because I would look at the report and say, okay, they're intermediate on 2C19, they're a poor metabolizer on 2D6, so this says I should start it at a lower dose, but then the other one says I should start it at the regular dose. And then I have 2 others that are telling me I should start it, maybe start it or start the recommended. And now I'm trying to figure out, number one, sometimes these tests don't even tell you for citalopram, look at these individual genes. You might just have all these genes listed and it be summarized elsewhere. Regardless, you wouldn't get one response. You'd be making guesses and assumptions that certainly were not grounded in any sort of evidence-based research at all, just whatever summary we're able to come up with at the time before we make the decision. Versus with a weighted impact, such as GeneSight, what GeneSight does is it takes the individual significance of these genes and applies it directly to that particular medication. And their algorithm knows okay, citalopram is metabolized in this part by 2D6 and in this part by 3A4 and in this part by 2C19. And because of these individual phenotypes and because we know the portions of the drug that are metabolized, we can then make a general recommendation on how to dose it. Those are algorithms that I think in one of our slide decks, there were over 350,000 different combinations that are possible with all of these different multi-genes that GeneSight then takes all of those possible permutations and gives us these bins. So instead of sitting here wondering, what do I do with citalopram, which in the first two probably would have led to me making the decision to just start it as normal. The reality is, knowing what we know about how citalopram is metabolized, I should start it at a lower dose. The SLC 6A4 tells me that I'm on the right track with an SSRI. That would be a good next course of action. But had I not had the weighted approach of GeneSight, I may have started citalopram at the normal starting dose, and that patient may have experienced side effects. And we may have then chalked that up to a failed medication trial, when had I started at the lower dose as recommended by a multi-gene approach, multi-weighted approach like GeneSight, she may tolerate it better, and then we may be able to see clinical impact. So I think citalopram is a good example. Sertraline's another good example of when the weighted impact is super significant. But in general, overall, both from a research perspective, where we're saying like GeneSight has studies and the science supporting which percentage of which drugs are metabolized, so that gets taken out of the equation for us. We don't have to make those assumptions anymore. To me, there's really just no comparison, because you're not even getting any sort of comparable actionable information from the other two.
I'd like to add something too. I think when you look at that multi-gene test there, because all of a sudden there's now multiple genes affecting this medication, most providers would probably throw their hands up, especially in the primary care space, and say, I just need to find something cleaner. And they would be scared away from it right out of the gate. Whereas you all of a sudden look at GeneSight's considerations and it's saying, no, you can feel comfortable using this. You just need to understand why and then move forward in the right step.
Thank you so much. I really appreciate that explanation. Dr. Wyrick, you kind of just hit on this a little bit, but I do want to bring it up, particularly in the primary care space. So when we talked about usability, interpretability of the GeneSight report, this green, yellow, red organization comes up a lot. We talk about what it means, what it doesn't mean, and how the clinical considerations are pivotal for getting the full utility of the GeneSight report, and how these different colored bins shouldn't be prohibitive to prescribing. It's just information for you to use. So with limited time in primary care, with the abundance of patients you're seeing, how are you explaining this organization to patients in a way that increases buy-in and that provider-patient relationship?
Yeah, I love patients to have a copy of their report in their own hand, because I want them to own this report. This is them, right? And so I will oftentimes get a lot of questions right out of the gate, because patients will bring their report in for that first discussion about it. And I love to highlight kind of where they've been, if they have been on other medicines, and where they fall, and kind of help explain that with regards to what the clinical considerations are saying. Hey, this does make sense why you actually did worse at higher doses than lower doses. And so not even having to have a depth of knowledge within the PGX world, you can look at these initial pages and understand, hey, something's out of yellow. Let me understand why it's out of green. Why is this in yellow? So I can help explain that to my patient. You can do that so quick. It's right there in front of you. And so the usability is incredible, and can, again, help you be efficient when it is on such a limited time basis. And I've still got 3 problems to address before I get that patient out of the room. I also really like, again, the multi-utility. For me, when we get outside of just, looking at the kinetic genes, I love to talk to patients about their dynamic SLC, right? That dynamic gene is so crucial for me to help patients have a little bit more of, some insight about themselves as to why are they maybe already having a mood disruption at baseline, right? Are they already having issues with regulation of their serotonin? I also love to talk about COMT and the additional test, the MTHFR, and those are again, important pieces that I try to help patients self-identify with, and again, is ultimately part of the treatment plan.
Thank you very much. I appreciate that. All right, and the last third major differentiator between GeneSight and competitors is that GeneSight is the only pharmacogenomic test on the market backed by such strong clinical evidence, showing significantly improved remission rates for patients with depression whose providers had access to GeneSight testing compared to treatment as usual or the standard of care. So one thing that we want to point out is that this particular slide here shows that the two largest pharmacogenomic trials conducted in mental health have been used the GeneSight test. So first was the guided trial, which showed a 51% relative improvement in remission rates compared to treatment as usual. And one thing I want to make sure that's understood is that when we think of clinical trials, naturally we think of treatment versus placebo. That's typically how they're created when you're testing drug efficacy. But for pharmacogenomic testing, the two treatment arms are both receiving active treatment. So treatment as usual means that a provider is using their best clinical judgment, clinical guidelines, all the acumen and tools they typically use to help their patients get better. In the GeneSight arm, the same still applies, but they also have access to GeneSight to help testing. So it's no longer treatment versus placebo, it's treatment versus treatment with GeneSight testing. And it's important to know in these trials that it is these two largest trials that it is only the GeneSight test being used. It is not other competitor products being used. So it's really important to understand that. More recently, the largest now pharmacogenomic clinical trial in mental health, which was conducted fully by the VAs across the United States, it was government funded, also showed a 28% greater likelihood of achieving remission when GeneSight was used compared to treatment as usual. And then lastly here, this was a large meta-analysis that aggregated multiple studies using GeneSight and found a 49% relative improvement in remission rates as well. So I tell you all of this because evidence matters, consistency and outcomes matters, and that is what has been shown with the GeneSight study here. And here, we also have some other notable differences listed here between GeneSight and competitors. These are, just things that are good to know that GeneSight offers. So I mentioned the medical affairs team that we have on call for our providers. We have a certain ordering portal that providers use. You're able to ship the patients home. We have an abundance of educational resources, a state-of-the-art lab with a very fast turnaround time, and we have great payment options as well. So these are just some differences that I think are really important to know. Each provider may have different things that they like better or more or less about using these, but here's just some that we commonly see. So I want to turn it over to the panelists now that we've discussed kind of the big differentiators between GeneSight and competitors and talk about your clinical experience. So one thing I wanted to ask each of the panelists are, what are some concerns your patients have ever expressed in regard to PGX testing? And how has GeneSight helped alleviate any of those concerns? So Dr. Nelson, we can start with you.
I would say two things. One, people will ask questions about their DNA. It is a DNA test, a cheek swab. So they'll ask questions about, what is the company going to do with DNA? And GeneSight makes that very clear that they're going to destroy the DNA. And the other thing is cost. That is always in everybody's mind. How much is it going to cost me? And myself and Anna Marie, we were involved with those other companies real early on, and cost was a very, very big deal. We were told that these patients would not get bills at times before the test, and not only would they get a bill, but they would get a very large bill. And that created more frustration. Again, we're treating psychiatric patients who are dealing with anxiety and depression, and then they would get a $1,500, $2,000 bill for pharmacogenomic testing. And GeneSight's promise, where that cost is $330 or less, and for many patients like the Medicare, the Medicaid, being free, is a very big deal because it takes that stressor off of the table when you're trying to order this test and get your patient to a treatment plan, get them to remission faster. So those are always my two things that come up, and I try to get that off the table early if they have concerns.
Anne-Marie, what were some of the concerns that your patients have expressed, and what ways can GeneSight or has GeneSight helped alleviate those?
So I think what I hear from a lot of patients is, well, so-and-so told me that that doesn't work, or they told me that it worked for their one daughter, but not for their son, or my last doctor said that pharmacogenomic testing isn't a thing, that it doesn't matter, whatever. Lots of like doubts about its clinical utility. And for me, I try to explain to patients that so much of pharmacogenomic testing and its utility relies on the provider's training and their ability to interpret the results and explain the results properly to their patients. So if we go into pharmacogenomic testing, even GeneSight, saying green means it's going to work, yellow and red means it's not going to work, we're all going to be disappointed. After a decade plus of using the test, if I went into every test thinking that, I would be disappointed every day, because that's just not the reality. What our responsibility as prescribers, providers, and those that are educating other providers as well as our patients, our responsibility is to look at what it actually is, which is, this is a test that if it's in the green category, that's telling us there is no genetic reason why I should adjust the dose or choice of medication in this person. If something's in yellow and red, that means genetically there is something in this person's DNA that could impact either the dose or choice of medication. Now, when you look at the research that GeneSight has done on improving clinical outcomes, right, it would make sense that you could still use a drug from yellow and red, right, with the knowledge of why it's in yellow and red, and have success with that drug. However, had that person tried that drug prior to GeneSight testing, when the prescriber likely didn't account for the reason why it may have been genetically suboptimal or yellow or red, then that person was probably far less likely to respond well to that medication. For example, aripiprazole. When someone's a poor 2D6 metabolizer, the FDA recommends that you reduce the dose by 50%. So I can't tell you the amount of patients who have come to me saying that they were tried on aripiprazole, they had horrific akathisia, they felt like they were crawling out of their skin, and they stopped it right away. Had I had a GeneSight test, done it, seen that someone was a poor metabolizer of 2D6, but I really thought aripiprazole was a good choice for that patient for whatever reason I might decide, if I start that at 2 milligrams instead of 5 milligrams, I'm giving them a much better chance of not having akathisia than if I give them 5, and that's more like starting them right out the gate at 10. So I like to give people that example because red and yellow don't mean you should shy away from them. And sometimes I might even use a red or yellow medication before I use a green one, because I want to use that drug. And now I know how to use that drug and how to dose it because of the GeneSight test. So I think setting up that realistic expectation for patients and explaining to them what this test actually does and can show you will help over time combat patients' reluctance to say, like, this is a test that could not help, or all the rumors about pharmacogenomics. And I think it goes both ways. People that both idealize it, and we need to help those people, and then the people who completely discount it.
I would even add, you talk about other provider skepticism when they get a report and they see, great, here we are. They've tried 4 medicines. They're all in green. I did nothing with this
That's a
report.
great
What am I
point.
going to get out of this? My favorite thing to communicate to them is this is a great opportunity for you to actually talk to the patient about how much stock they're putting into swallowing a pill to solve all their problems, right? At that point, it's a great opportunity to really focus on, well, how are we doing with our physical health in addition to this, right? Did we really give this adequate trial? Did we set the right expectations for you to understand that we're just trying to elevate mood just enough so you can do the physical things well to ultimately overall improve your health? And so again, that's where the multi-utility really comes in, when you're comfortable using this test and knowing what you can really get out of it.
Yeah, and to just to add to that, I say this often. when someone shows up in my office, because by the time they've gotten to me in psychiatry, they've tried, failed so many medications.
Right.
They show up and all their green, all the green medications are not working. First thing I'm going to come back to is also, is the diagnosis correct? It really, when you get that report back, if you're getting outcomes that just don't seem quite right, it should make us dig a little deeper. We're going to ask more questions to the patient. We're going to ensure we got the diagnosis right. Like Dr. Wyrick said, what else is the patient doing to collaborate with you to get well? Do we have social situations that we're missing, psychological situations like domestic violence, things like that can really skew the entire picture. So the test has just so many uses that can move us to getting our patients better faster, period. So
I love that. And I think it speaks to what we try to talk to as much as possible, is that it's one piece of the puzzle. Pharmacogenomics
Right.
is one piece. It's meant to be used in conjunction with all of the other clinical factors you all beautifully described there to make a collective decision. And I think when, I hear sometimes when Anna Marie was saying the patients are like, GeneSight doesn't work, quote unquote, you have to set the expectations of what work looks like. Work in this instance means, was it the genetics correctly identified? Was it run properly? Things of that nature. But it really has nothing to do with, green means it's going to work, red means it doesn't. So I think you're 100% right. Love hearing that. It really is important to set those appropriate expectations for what it is for your patients. I think that was communicated beautifully. So thank you. One question that I think is really important to discuss on this webinar, because we get this question a lot, is when and who are you using GeneSight testing on? So we have providers in different walks of medicine on this call for a reason. You all see patients at different parts of their treatment journey. So Dr. Wyrick, we'll start with you as a frontline mental health care worker in primary care now. When are you using GeneSight and who are you using it on?
Yeah, there's not a perfect patient type to include, exclude. I think the conversation needs to be started early. And I mean that as soon as someone comes in for the first time talking to me about anxiety, depression, whatever it is, we go ahead and talk about all aspects, like those expectations we talk, but then I love to set them up to already be thinking about GeneSight, because I say, hey, we may try this. We need to be patient with it for 4 to 6 weeks. But if you're frustrated with this, that it's not getting us where we need to go, just know there's a tool that we can utilize to help us make a better next decision for you, or help us understand maybe why this didn't work for you. And so a lot of times I won't use it right out of the gate because I haven't had a lot of people try and fail medications. But at that next visit, I have a lot of patients that come in already saying, I'm ready to do GeneSight, and so it makes that second step a lot easier. But I also get the same patients with multiple medicine failures transferring from one family doc to another and coming in, shaking their heads right away, or already really negative about, I've tried everything, there's no help. Well, let's get that test right away. Let's figure this out. So there's no age limits for me. I love to use it in my adolescent kids too. And it really sparks a lot of parents to even understand a lot about themselves once they see reports on their kids, and vice versa, right? If you're doing it on that parent and they all of a sudden want to get to know a little bit more about, maybe what their son or daughter's genetics look like. So and I would go into geriatrics in a whole nother conversation, that becomes a whole nother realm of, now we're looking at an aging liver that maybe isn't as efficient, and maybe are some of these genes a little brighter now that they're older. And so I know Crystal does a lot with geriatrics, and so I'll let her have that part. But I think about it in everybody.
Wonderful. What about you, Anna Marie?
I use GeneSight in all of my new intakes, which I know is not the way everyone practices, but I always go back to when the original guided trial came out for GeneSight, there was this slide, and I'll have to find it and bring it up, probably frame it on my wall someday, but it looked at how much you could increase the chance of remission if you captured people who were on a red or yellow medication at the time they came to you, and you switched them to a green medication. So you took a medication that was genetically suboptimal and made it optimal. And it was I don't want to misquote, but I believe it was like 138 times more likely. And so I thought to myself, if the coverage is great, which it is, and people can afford it and they want to do it, I would rather have the information and be able to make actionable change from it, whether it's now, 2 months from now, 7 years from now. I actually 2 months ago updated a test of a kid that I tested in 2013. We just updated his test 2025, which was super cool to compare the two reports. But GeneSight will constantly update the reports for you. You have to do new samples, but they don't charge you again. So once you do it, it may be an investment, but it's an investment that continues to pay over time. And I've had nothing but great results from using it as part of my intake process.
Thank you. And what about you, Dr. Nelson? Who and when are you using it on?
Yeah, so for me, as I shared, the majority of the clients that will get over to us, they've already failed. So they've already failed a lot of medications. We see all ages. My focus being geriatrics, those patients, again, that's a whole other conversation, but those patients we all know are quite complicated. And so majority of my clients are getting the test just right out of the gate. It's shared with them during the intake process. So new patients, it's shared with our new patients that is something that we do to get to a medication outcome faster. And the clients appreciate it. By the time they get to us, I always say a lot of times they've been wounded and that they don't have trust. They feel like they've been guinea pigged, a lot of trial and error. There's a lot of hopelessness. Again, by the time they get to us, and they may have even had to wait for weeks or months, sometimes even. So we're trying to get to that medication selection as fast as possible and get them into remission as fast as possible, if that is a doable thing. Also, it helps us to kind of triage our patients because, again, by the time they get to us, they might not have a lot of medication options. So if we need to move to something like transcranial magnetic stimulation, or we need to get that person off to, maybe even trying Spravato, ketamine, something, we can triage those patients and get them into the right space and place a lot faster because we know we have a smaller amount of time, just with the nature of how acute they are by the time they get to us.
That makes a lot of sense. Thank you for sharing. One of the next questions that's come up a lot, we've seen it in the chat and I've heard it many times speaking with providers. This is another tool. This is something else you have to integrate into your clinical practice, and it takes time. So how have you integrated this into your clinical workflow? Who is identifying patients that are candidates for this? Who's doing the cheek swab? How are the orders being sent out? How have you made it work in your very busy lives? And anyone, feel free to start on this one.
Yeah, I've got well-trained nurse. And so, the conversation is always led by me. And once the decision is made, it's easy. I get to walk out of the room and I get to be already into the next patient. The nurse takes over from there, takes in the folder. And she can and she's very well aware of the poverty chart that helps kind of even elucidate maybe you might have a lower cost than that 330. And then the cheek swab is done. Everything is inputted right there on the portal via the ordering system. And my notes are done right after I leave the room. And so they know to look right in my note to see what's been tried, failed, and what we're considering augmenting or switching to. And so right there, FedEx is ordered right as soon as they sign that order that comes to me for that final review. But it's quick and easy. It is not any additional work for me once I've had that conversation and had that buy-in from the patient.
Yeah, when we started it, it was really important for my entire office to understand GeneSight. So I made sure that from our intake person all the way to our front desk person, that they all understand what GeneSight is. So it's explained up front on the intake. We have kits that they can swing by the office. There's a box in the front of our office, so they could actually swing by and get a kit if they needed to. We have kits for clients that are at home and we're doing telehealth, the kits being sent to their house. If I'm seeing the patient in the office, or my MPs are seeing patients in the office, just like Dr. Wyrick, I see them, send them out to the front. They're swabbed right there at the front desk at checkout. and the kit is collected right then and there. So everybody in our office really understands what we're doing with GeneSight, making it pretty easy for us to get those samples, and the patients know from the beginning that that might be something that they're asked to do at their visit.
And who and when are you using it on, Anne Marie?
So I am a one-person show here. So when the pandemic happened, that actually really helped me because the GeneSight at home like took most of the work out for me. So even though I'm back to seeing patients in the office full time, I'll still have the kit sent to their house. So I place the order usually when the patient's in front of me. It takes me like under 2 minutes to go through my portal, put it in. They do all their stuff at home. The report comes to my inbox, and then we're done.
Yeah. And I'd even throw a shout out to, our regional sales rep, whenever there is any questions that come up with, this test kit sat too long and I'm not sure if it's good, there's always, a quick response in terms of, no, you just needed to select this a little differently, or no, that sample's still good. Go ahead and reorder that shipment. There's a lot of good response there on the customer service aspect.
Thank you so much. It's a question we get a lot, how do you make time to do something like this? So I think it's really important to share your clinical perspective on how you fit it into your clinical workflow. Last question is for Anna Marie, and if anyone else has feedback on this, of course, please chime in. You focus on pediatric psychiatry as well. So how do you introduce GeneSight when engaging with patients and patient caretakers?
When I talk about GeneSight with particularly in the pediatric patients, there's several things I consider. One, it's helpful just for my knowledge because I want to have all the information I could possibly have before I make a decision about medication. Two, when you have kids that either haven't been exposed to any medication before at all or have like a pretty short history so far, we have the opportunity to shape the way that these kids and their families view psychotropic medication now and in the future. So ideally, with things like GeneSight, when our 7-year-olds of today are our 47-year-olds, 40 years from now, we're not having the same trauma when my current 47-year-olds are telling me this happened with this medication and then this happened with this medication, and all of this distrust with providers and medications and compliance issues because they had too many side effects. And by the time you get them in front of you, you're convincing them that there is some hope that something out there might potentially work and not have 10,000 side effects. So if we can improve individuals' contact with psychiatry from a very young age, I think that will make a huge difference in terms of decreasing the stigma surrounding mental health and mental illness, as well as increasing adherence and compliance and willingness to engage in treatment. So for kids to have GeneSight, to be able to identify, say, poor 2D6 metabolizers at the age of 7, like imagine what we could save them from when we know there are so many drugs that their serum level could be double just because of that one gene alone. And then we combine it with, 3, 4, 5 other genes where they might have a mutation, and we could be potentially sparing these very young children like months, years of trauma, side effects, symptoms that are untreated. I'm sure we've all had the experience of having a patient who's been so severely depressed for the last, say, 7 years. They come see you, you guys work through things, you get the diagnosis right, you get the therapy right, you do GeneSight, you put them on the right medicine. And then when everything's great and they're like, oh, thank you so much, I sit back and say to myself, like, could this have happened 7 years ago? And that's really sad to me. So my hope, and when I talk to patients and kids about GeneSight, is to not have stories like that.
I would definitely, just completely agree 100% with you. We see kids in the office, and when I do see a child, it's really important to me that we empower that kid at that point, because this is a printout or a blueprint for them on medication management that will work with them, go with them over the course of their life. So often I will get a young adult who is, 25 years old, and they started medications at 12 or 13, and they have gone through so many medications that by the time they're 25, the level of distrust that they have and that they could even reach remission. I've had patients, young adults, cry in the office when we do a GeneSight test, because they will say exactly what you just said. Could this have been done years ago? Could I have gotten on this medication years ago? Why wasn't this done? So it's really important that we do not, leave out those children, because I know, there are moms on the group. None of us as moms, parents, we don't want our kids guinea pigged on. So, if there's a way to get your kid on the right medication, if medication is the best option for your kid, we would want to get the kid to that medication much sooner. The other thing is, I really like giving the reports to children, especially teens, giving them the report and letting them take ownership of it and writing on it. So if they start a medication and we end up changing that medication, for them to write on the report itself to say, hey, I started this medication, 2025, and I had this side effect, that helps the future mental health provider that will see that person down the road to understand why now are they on drug number 6 and what happened. One of the hardest things that I do on my end is when I get, whether it be a kid or a young adult who's failed 10 medications, I have no idea why. I have no idea what happened. Did they actually have an adequate trial? What was the side effect? So the report, sometimes for my teens, I'll say, this is like this is going to be your psychotropic little Bible. You keep track of it, you write your notes in it, and you keep that with you to carry with you over the course of this journey that you will be on with your mental health. So it's a really useful way. The other piece, you can have a conversation about food with MTHFR. You can talk to parents now about what the children are actually eating, and talk to them about how serotonin and dopamine are made. So it really provides this platform for you to have an educational conversation as well with parents and kids, because we know they're not eating anything green at all, but we need them to. And so when you show them, hey, you're not converting all of your folic acid that you need, and here's where folic acid comes from, there's a light bulb that goes off in those kids' minds and those parents' minds. So a great starting point for good conversation with kids and families.
Yeah, and again, then they start to understand themselves a little bit better. Oh, it is my MTHFR that's off. Oh, my SLC is off. It's not just that I live in social chaos at home and that I have a bad relationship with my parents. I'm already a little prone to irritability and feeling off a little bit, mood wise. So
Yeah.
again, helps with buy-in. They know that you're treating them individually.
Thank you so much. That was so powerful. I can't think of another way to end the webinar. So I want to thank you all so much sincerely for your time. Thank you for all the attendees for your attention, your questions. There are some questions we saw in the chat that we will follow up with after the webinar. And as I mentioned, this webinar will be available on our recording on our YouTube channel as quickly as possible. So thank you, panelists, for sharing your wealth of knowledge. I sincerely appreciate your time. And I hope you all have a wonderful rest of your evening. Thank you.
Thank you.
Thank you.
Yeah.
You guys
Thank
have a great night.
you.